Good morning, everybody. Welcome to the Finance Committee. We'll call to order. Morning. I understand there are no citizens signed up to address the board committee, so we'll move on to item 3, which is approval of the minutes. I'll entertain a motion to approve the minutes from the, we have a motion? Second. All in favor, please say aye. Opposed? Motion passes. Thank you very much. Move to item 4, CFO report. Ms. Clark. Good morning.
The CFO report today.
I don't know if that mic, I know that mic is not on, but the other one is.
Better now?
Yeah.
Okay. I just have one item on the CFO report. As you guys realize, we have been going through the process of the external audit RFP evaluation, and we have made the final recommendation to continue with BKD as the incumbent. And I just wanted to give y'all that update. The final contract, because it's under $200,000, will not be coming to this committee for approval per se, but I did want to let you know that the committee did make that final recommendation. So.
Thank you for that. Any questions of Ms. Clark?
All right.
All right, we'll move to item 5.
So for the month of May, we have, although our statistics were strong for the month of May, when we get to the income statement, you'll see that it was a very difficult month financially for the medical center. Admissions, however, were about 6% ahead of budget. We did have over 2,300 admissions in May. Patient days, as you can see, were also strong, about 3% ahead of budget. Our CMI, you're gonna see this in the inpatient revenue, but our CMI was slightly under by about 1%, which means that the acuity of our patients were slightly lower than expected. And our length of stay was slightly down as well. There's a story on this page on our key outpatient statistics. If you'll look at that blue line on the emergency department visits. This month we had 11,379 visits in our emergency room. For the month of May. That is 367 visits a day, and that is the highest of the 3-year trend. So although we had budgeted a very high amount, that is an extraordinary amount of people to see in that emergency department.
That's one every 3 minutes.
One every 3 minutes. So that does not include the folks that came in and left without being seen, but that is a tremendous volume that went through. So again, we always talk about how busy our emergency department has gotten over the last 2.5 or 3 years. That is the highest on that 3-year trend graph. So I just wanted to again point that out to the committee. We are currently trying to expand some beds in that area through some capital that was approved this year, but very, very busy month on an outpatient basis. Down below in the urgent care visits, they had an extremely busy month as well at over 5,200 visits, about 12% over where we had expected them to be for the month. So again, those kind of combined show you where the walk-in volume was. Our total clinic visits, again, a high on the 3-year trended graph. We saw over 63,500 this month in our outpatient clinics, about 3% higher than our expected budgeted volume on an outpatient. And so therefore, our outpatient visits down at the bottom right, almost 5% over for the month of May.
Karen, do you include psychiatry in the past?
They are in the total outpatient visits. And I believe they are in the total clinic visits as well. So if you look at the right side of the page in the total clinic and the total outpatient, the next page for, when we talk about the clinic, the outpatient on 2 slides later, that's kind of repetitive and they are counted in both. And the other key statistics, and this is on page 19 if you're looking on your portal, observation days were slightly down from budget, slightly above budget at about 1%. They were slightly down by about 8% from budget. Invasive lab cases continue to trend above budget. That's a very busy service, about 6% over. And surgeries this month were extremely busy. Inpatient surgeries were about 1%, 1.5% above. And outpatient surgeries, again, a 3-year high. For volume, if you look at that blue bar chart, we saw over 850 outpatient surgeries. And in talking to Wanda this month, it wasn't just one type of surgery. It was just, we were busy in all outpatient surgeries for the month. Again, a lot of that could be attributed to what's coming in through the emergency department as well, about 7% ahead of our budget. So, and then in psych, all of the statistics are above budget. Our patient days were trending, once again, a 3-year high, over 3,800 inpatient days for psychiatry, and our clinic visits were about 5% ahead as well. And I want to spend a little bit of time talking about the Psych ED and what impact that had on our financials for the month of May. When we look at the psych emergency department, you never know exactly what's going to be coming in, who's going to be walking up to the PEC. And when you reach capacity, and when I talk to Wayne, that's about 40, when you get to about 40 waiting for beds up there, 40. We can hold those folks in the PEC for about 24 hours, and then we have to find them a bed. And we call that outside medical services. If our beds are full, which often they are, we utilize community resources for our self-pay and our connection patients. And we pay for a bed within the community. And we have contracts which you guys approve. Those patients will be outsourced there, which relieves the pressure in our psych emergency department. But that impacts, and you're going to see that impact for May on our purchase service expense. And it was significant this month for May. If you'll also notice, we had a pretty high volume in April and May. So I just want you to understand what these volumes are going to be having potentially also in June, as some of those outside medical services expenses are going to be paid in June as well. Now, June does not feel so far as busy as May has been, but we will find out very shortly if we have had to access those contracts for outside medical services as heavily as we did in May. So these volumes, you know, as we've gone through these graphs, I really these are key volume graphs, and these, as these volumes roll through our financial statements, some of these do have key relationships to how we're going to perform the month against budget. So the psych ED did have a very significant impact on our May results. Our FTEs per adjusted patient day was favorable year to date, and again, this view kind of keeps us year to date. So through May, we are at 5.91 compared to our target of 5.96 FTE paid per adjusted patient day. So we are under our target. And then the two main financial graphs that we look at each month are days cash on hand. We're at 288 days. And our net accounts receivable days are remaining at 53 in May. And our payer mix pie chart has not changed significantly. We're still hovering right around 39% unfunded, with the self-pay as well as the connection together. And did you have a question?
I have a question for you. How many DSRIP employees do we have that are not included in the,
I want to say it's about 220. I would have to verify that with you, that we pull out of that FTE calculation.
why do you pull it out?
So what I report to you on the 5.91 to 596 is all in. We
Okay.
also traditionally before, for years, have done an FTE with exclusions. So if we were to go out and benchmark ourselves against other hospitals, other non-public hospitals, we may want to pick up the with exclusions number. Because we're a teaching hospital, we may not want to include our residents because non-teaching hospitals may not have all the residents that we pay. We have an extraordinary amount of DSRIP employees that non-public entities may not have. Other non-publics may have, let's say, 20 DSRIP employees versus the 200 and some odd that we have. And because we have the whole correctional health service line, that is a very unique service line that if we were to compare ourselves out there, that would be unique.
Well, it
So
wouldn't be fair. It wouldn't be fair.
we had always pulled, that is just one view. So we, instead of completely changing the way that we calculated the FTEs per AOB, we just did it both ways.
Okay.
So I typically look at it all in because that's who we're paying, and we kind of need to look at it. This is who we pay 100%, and then I wanted to keep the way that we look at it historically. And if we ever do go out and wanted to see how we benchmark against others. So we've just left the with and without exclusions on the report each month.
Thank you.
You're welcome. So on the connection enrollment, we had about a 600 enrollee increase, about 1.5% on that. So we are starting to normalize, it looks like right around 40,000 enrollees for the year. So for the month of May, again, we missed budget this month by almost a little over $3 million. And the medical center itself lost $1.9 million from operations. From a top side, we actually performed better than budget on a gross revenue or a net revenue standpoint. What happened was there were some substantial expenses that were not expected, and we'll cover those here in a minute. So from a revenue side, we talked about the volumes, and we did have good inpatient volume. From a admission standpoint, however, we had a shorter length of stay. So from a revenue standpoint, we just barely had a gain on inpatient, but we had almost a 5% increase on outpatient. We did have an unfavorable payer mix this month, so didn't have a huge pickup, only about a $723,000 pickup on net patient service revenue. We are kind of holding back on our waiver accrual of that $833,000, and we had a pickup of about $317,000. You can see there in other operating revenue. We had a vehicle tax pickup from budget that came in all in 1 month, and we had several grants and reimbursements that we were able to get in May. So our total operating revenue came in at about $300,000 favorable. When you drop down to the salaries, it was $1.4 million over budget. We did have about a $300,000 one-time payout for a retroactive merit payout, but we also, had the volumes from outpatient as well as our patient care beds. We had overages in our patient days. So from a staffing standpoint, some of those days, the volume increases. And, from a month standpoint, it was also favorable. We were at 5.85 FTEs paid versus a 6.03 for the month. So, we had to staff for the overage and the inpatient and outpatient volumes. When you drop down to the benefits line item, there's an $800,000 overage there. And if you remember our discussions back in April, we had some overages in our employee health that occurred. And we had another unfavorable month in May with some employee health claims. So for the last 2 months, we have had some large claims come through. If you recall, JPS, as most large employers are, is self-funded for health insurance. And when we do accrue for large claims, but when extraordinary large claims come through that have not yet hit our self-insured stop loss, those will hit in the month that they come through. So we had a large number of claims, and we had a handful that were greater than $200,000 for both April and May. When you drop down to the purchase service line item, you can see that it's $1 million over budget. And the largest majority of that, $700,000 of that $1 million is for outside medical services, where we were talking about the overflow from our psych emergency department, where we are having to place with external resources for overflow. That is where those expenses hit. We also have, in addition, about $300,000 for things like the blood bank, the laboratory, and our outpatient, or some of our pharmacy expansion that we've outsourced, hit the purchase service. But again, about $700,000 of that overage is due to some of those psychiatric inpatient beds that we have to outsource when we get to that pressure point. Are there any questions about the month of May? It was a difficult month financially.
Any questions for Sharon?
On the income statement, when you put hospital only, that does not include the medical home.
What did you say, DT? I'm sorry.
Move that
It does-
mic over if you
No,
can.
I'm just looking to see what, on the income statement, when it said hospital only, that's just purely hospital,
When you say it doesn't include the medical home,
does that go to that side or the other side? I'm just trying to see where we.
so it's the medical center. It does not include a claim or the foundation. So I'm not sure
But it does
I'm
include all
following
the
your-
clinics. I mean, it's,
It includes all of the clinics, so it's really the tax ID number that is all things medical center. It just does not include a claim or the foundation.
Just wanna make sure.
So, all of the connection expenses would be included in there. All of the community health clinics are included. All of our outpatient business would be included as long as it's a hospital-based service.
yep. Okay, you want to move on to a claim?
Sure. So a claim this month, their volumes were consistent with last month. They were about 4,800 visits low, or about 7%, which is consistent with the positions that they still have open and are recruiting for. Most of those are vacant in primary care. And looking at the top net patient service revenue line, about 8% under in their net patient service revenue. Their other operating revenue, you'll notice, is $700,000 over. That's due to a payment that was unexpected for meaningful use. You may remember last month, we got a small payment for meaningful use, and we got another much larger check for about $700,000.
That's
this
probably
month.
it, right? It's probably the last of the MUs.
And that is all that we expect.
Yes, that's it. Bye-bye.
You know, with all of the transition that happened with the UNT physicians, we really were not exactly sure how these monies would flow across. But yes, this would be the last payment that we would expect to receive for that activity. Some of the operating expense categories, the salaries are over by about $230,000. The salary overage is not related to any of the physician payments. It's more related to an intercompany transfer of activity. There are certain departments that have gotten moved over through the year. There's the trauma team that came over, and there are some other providers that support that have gotten moved over from a claim, or from the medical center to a claim. And the medical center does fund those people, but they do show up in that salary line item. So that is what's occurring in that salary line item there. And then we do have a small overage in the purchase service line item. Again, as legal and the consulting try to finalize some of those contracts, and Jay Taylor that you heard from last month. So the income from operations, just over $1 million loss compared to $729,000 loss. So a claim missed budget this month by $284,000. Are there any questions on a claim for me?
Okay.
All right. Thank you.
We do have a question. Go ahead.
Is there a way we can see the breakdown? Regular normal run rate and the increase in expense. Temporary,
I need a hearing aid, I guess.
A good handle on how we spent in this area.
Could you restate the question as you understand?
You were asking if we could potentially see a breakout of the normalized expenses versus what we might be seeing, spending on locum tenens coverage.
Right.
Right now, the majority of the expenses are the staffed expenses, the employed. I do not think that we are spending too much on locum tenens. That would fall in that contract labor, the $236,000. We can definitely work on a detailed report out. I don't know that I would recommend modifying the board level report, but we can get you some detail and see what you might need on that. But currently, there are only a few departments that I believe have, that are being staffed with the locum tenens. I think neurology is one of those, and I think we're working on looking at maybe a few of the primary care clinics on what that might look like if we were to try to backfill with some temporary staffing from a physician coverage standpoint.
Because what I'm trying to do is trying to understand, because we did not plan for integration and implementation when we merged the two together. So at what point do we see the smoother line from the up and down of, things, so that later on, if there's another group coming in, at least we know, hey, we need to be careful with this, and this, because it will happen, or just recruiting, or if we see more recruiting, that means we may have more turnover than we expected, and
Right.
that way we can kind of extrapolate that and calculate to see what would that impact our revenue also as well, because during the transition or looking for, we have open, we can't schedule people or something like that, so.
Right.
Okay, any other questions for, yes, sir.
Real quick, should we expect to see this again for the next several months, where we're gonna see more expenses than we thought?
On a claim, I think we've, when we talked about where we thought we would end the year with a claim, I think this is kind of the normalized performance on a monthly basis for a claim for the next few months. And I think we'll probably end the year at a claim at around the $12.5 million mark, I believe we said. On the medical center, what I would expect to see, I'm hoping that the employee benefit is not, I'm hoping that's just a one-time anomaly for April and May. We went for 6 months without having an overage. We were not over year-to-date. on our performance until April. We had not seen an overage in outside medical services until this month with psych services for that. So, you know, some of the things that hit us in this month were really one time. I don't know if I can call them an anomaly because they're part of a normal operation and they could happen, but they had not impacted us to this extent until May. So the 2 or 3 big things that hit the medical center all in 1 month, I don't want to say that we're going to forecast the medical center. I'm hoping that the 3 things that hit this month will not hit again in June. We do have to wait until the end of the month and the benefits reports are sent to us by Cigna to see what's going to happen with benefits. We don't have a way to get a sneak peek into that. You know, outside medical services may be over next month because of the lag in us getting the bills from the contract providers. But I don't have a way to answer that question right now, today. And a lot of June is gonna depend on how our payer mix ends the month for June. But I would not expect to have an operating loss for any reason in June and July,
At the risk
given
of,
what I know now.
at the risk of asking kind of a noob question, still, let's say we have a surge in need in, say, psych, and we have it staff, and we have people that are taking care of the folks, and we see a surge. Where is the decision made to say, we're gonna go to outside vendors to help us with this during the surge, or do we say, well, we're just going to tell people there's longer wait times? How does that decision come about?
So as I understand it, as the finance person.
Right,
I've talked to Wayne about this a lot. Where that decision is made is you're in an emergent setting with, in the psych emergency department. You can hold those people, and a lot of those people are not brought in, they're brought in by, not on their own accord. They can often be brought in by police, and they cannot be released on their own accord. So they are here. You also have other people that may be coming in behind them, either being brought in by police or just coming in on their own, or being brought in by family members. So you're having this constant flow. Our capacity is to be able to hold for evaluation. You don't want 40 there, but that's the breaking point, is 40. So when you have 40 waiting for a bed, you have to make decisions. And part of that decision is you have to find some of those 40 that are in line of bed. And you can really only hold for evaluation for about 24 hours. So it's kind of first in, first out. And if we can't discharge who's already in our beds, so we have 36 or 38 at the newer facility that we opened a year and a half ago, and we have another 35, 40 beds here downtown. If those are all full, then the only relief valve that we have is the 4 external contracts that we can access. So we have to find those patients that are in the waiting queue a bed. Now, if they have commercial insurance, then they're not going to show up on that purchase service line item. But if they do not, if they're connection or self-pay, we still have to get them into a bed in the community, because it soon becomes a safety issue in our facility if they do not have. They cannot go into a medical surgical bed. It's not a bait and switch.
So does our system kind of assume that a certain number of emergencies are going to occur over a month? Or do we, and then if it goes above that, then we are going to wind up using the outside?
From a budgetary standpoint, we assume from an annual standpoint that we're gonna spend, what we spent last year on outside medical services. So, you know, year-to-date, up until, April, that had held true. So we assumed that the psych emergency department, we really had not made any volume changes from 17 or 16 to 17 assumptions on volume and that, and we really didn't make any dollar change assumptions for outside medical services from 16 to 17.
We do have more facilities today than we did a year ago, right?
From an inpatient, but then it's complicated because we also contracted with MHMR to be able to take on more of their inpatient load as well when we opened up that additional facility a year and a half ago. So we agreed to be able, not all of our inpatients come through the emergency department. A lot of them do, but not all of them do. So,
Well, I know you're the finance side of this,
Yeah.
but it seems as though we increase capacity only to use it all up immediately. Is that right, Aaron?
and there has been, our facilities
You're
are not
exactly right.
always full, you know, that we don't always, you know, there are days where we might have 5 open beds, and it's not always an access issue, but then there are days where we have 40 that are being evaluated and we don't have an open bed. And there are days where, you know, even though we have dual rooms, there's a patient that you just can't put another patient in. And you don't, you know, for different reasons, you can't double up a patient. We won't go into.
No, excellent question. Very good question.
If Wayne were here, he could probably have done a much more eloquent explanation of that, but
Yes, sir.
Well, I just wonder if we have a legal obligation, if these patients come here, things like in Tala, if they come here, you just close your doors.
Well, that was a question,
I think that's what
that was a
you're really
question I was going to get to, but I decided not to. I'm assuming that some of these guys are MTALA qualified, if that's the correct term,
They all would
and some
be.
are not.
they all
So-
would be, yes.
But what I'd hope, and again, I know this, is that we have some plan to say, okay, 20% of our capacity or 10% of our capacity, some portion of our capacity should not be scheduled, but should be planned to be unscheduled, people that are coming in from MTALA situations.
All right.
It'd be interesting to know that, but not today.
Gotcha. Good questions.
Do we know how much is our expense per bed, per day on the psych side?
What's the question? I'm sorry.
How much is spent per day on the psych beds?
Per bed, on site?
We've done some high-level analysis. I mean, you know, you and I can sit here and, you know, am I gonna, I'll know in about 9 months. I can give you a really good answer after we get cost accounting finalized. But, you know, from a psychiatric cost standpoint, a psych cost per bed is much lower than a med-surg cost per bed. Was that kind
Yeah,
of your
'cause
question?
I'm trying to look ahead as we build the new hospital. Because the number probably may be incorrect the last time, but it shows that the potential is about 7.1 million and then when I look at that, if you take that as a gross billing, then the reimbursed billing is less, about 30% or 25%. So when I extrapolate that, I thought, wow, we only get reimbursement for about $219 per bed per day. So when we contract with people, you know, at least we know in our back pocket, we get more than $219. When we
You know, I
when we
mean,
look
from
for
an
that.
outside medical services cost, I feel confident that I could perform the services for much less than I'm having to contract the services out for. But you only, you know, you don't necessarily want to build the capacity for, you know, the couple of days a month that you need that overflow. So it does take partners to be able to, you know, when you do have that 1 month high, the 3-year high, that you have the community partners to be able to help you with that. So you have to be smart in how many beds do you need?
If we had 9 months of overage, you know, that we might look at a more
Correct.
strategic approach to.
What I'm trying to get to is, you know, for long-term planning, right?
Right,
I don't want to get into a situation, like a better way of saying it, is like the government borrowing money from Social Security to pay for other
Okay.
stuff.
right.
So I want to make sure that the stuff that we carve out for JPS connection, we know, because we don't know, you know, just like the health insurance side for our employee, when that thing is going to spike. So
Right.
we need to do a better job on that, but lack of that, we want to make sure that we spend within that, so that on rainy day, we don't cut service, because we already borrowed to pay for something else.
Pay for something else, right?
That's what, but I can't get my hands on that side of it, but hopefully that cost accounting may give us a better visual on that later on.
Okay, any other questions for Sharon? I think I'll accept a motion to accept Ms.
So
Clark's
moved.
report. We have a motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Sharon. Now we've got some contracts to go through, which we often do here in finance. And it's Gina and Joe show. Good morning.
Good morning.
This is item B.
Item B, this is a contract we're bringing to you for, between JPS and R.J. Huntley. It is for the rental of specialty beds for our wound care, critical care, and bariatric services. This did go out for RFP. We received 4 responses back. We are asking for this to be our second of a dual source award. The other contract has been completed and executed. So this is the second of the 2 from that arrangement.
Any questions for Gina or Joe?
What are the beds we're,
They're for critical care,
Yeah, but I mean,
they're just specialty beds that we don't have in-house.
who's the
Standard.
vendor, who's the company?
This is with R.J. Huntley.
Yeah, the beds are Baramax, Rotorest, Rotoprone, and Kin-Air bed surge, so they're very specialized beds. Yeah.
Okay. You've heard the presentation. Any further questions? I'll entertain a motion.
You got it. So
Motion by
moved.
Dr. Weber, second by Mr. Powell. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you.
Thank you.
Diana, item 5C. Good morning.
Good morning. I'm asking for approval for a 2-year professional services agreement between PAST, or Physician Assistant Services of Texas, and Acclaim. This is a contract that formerly was between the hospital and the group, and now it will just move to Acclaim as these contracts come up for renewal. This is a 2-year contract. These assistants to take care of our cardiologist when he's in the OR. We're asking for your approval.
Any questions for Diana? Motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Diana. Ms. Peebles. Good morning. Item D.
Okay, I'm presenting today a contract for biocomposite bone filler, and what that is it's a component, a composite that the surgeons can use to fill gaps in bone if the patient has a tumor or a traumatic injury or something like that. And this is a product that we've been using on a consignment basis. However, our OR staff, Deb Saunders and Jeff Woods, are going back and negotiating all of our contracts and trying to get us better pricing. And so by going to a contract, we can save $42,000 over the term of the contract. So that is why we're asking to implement this contract at this
You know
time.
how just to say the right thing to me, don't you, about saving money?
That's what we're trying to do.
All right, you've heard the presentation by Wanda. Any questions? Motion by Mr. Nguyen, a second by Ms. DeBose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Wanda.
Thank you. The next agreement that I have is related to our skilled nursing facility. As you remember, we presented a while back to close our skilled nursing unit that we had on Tower 9 and to convert those beds to inpatient beds due to the high boarding that we were having in the emergency department. So we have been negotiating a case-by-case contract for those patients to go out and receive services since we closed that. However, if we go to a contract now, so that we have that and we're not having to do a case-by-case agreement for these patients, it can save us 40% per patient and $1 million annually. Plus, it also saves us a lot of time. When we do a case-by-case agreement, it takes 2 to 3 days sometimes to get all the contract worked out, which delays having beds for patients that are holding in the emergency department. So from a business sense and from a patient safety and care sense, it makes sense for us to go to a contract rather than negotiating for every patient. that we're
Better
in.
service, better care, better price.
I do have a couple questions.
Yes, sir.
What doctors cover these patients when they're in the nursing facility?
Actually, we have an agreement so that our doctors can actually see them there. And they've already been seeing them there, some of them, the residents and some of our physicians. This company that we're using can actually see those patients there. Some of our nurse practitioners
Yeah,
will
if there's
actually see those
physicians
patients.
that have a contract with the group that are not our physicians, how do they show to us that the quality of care is met, any metrics are met? I got confused in reading the whole.
We have an agreement with them that they have to meet certain quality metrics. They also have to have a care plan with the patient's primary care doctor that will be following them, and so that they're communicating back and forth with them. Our case managers also follow those patients regularly while they're in those facilities so that they make sure that we're meeting all those metrics and that they make sure that everything that we've set up in our contracts are being met by them. And Kay Duncan, our executive director for case management, follows those patients the entire time that they're in those facilities.
Okay, so our case managers manage our patients when they're in.
Because we have this contract, because we want to make sure that they're not keeping them longer than they need to be, or to make sure that they're not ordering tests or doing things that we didn't agree to, and those type things. So yes, they follow those
They
patients.
have to employ a specific nurse manager that reports weekly in that process. That
I mean, are there
company,
patient protocols that have to be followed, or?
as part of.
Assumption.
As part of the treatment plan.
It's part of, they have a treatment plan for every patient that goes there. Yes, sir.
Thank you.
Yes, sir.
Where are the facilities, and do we know what their capacity is?
Yes, sir, there is a downtown facility here in Fort Worth. There's also another facility in Arlington, and they have made an agreement that they will have beds available for us at all times. They have a female bed and male beds available, and also bariatric beds, and they've agreed to make sure that they have capacity to treat our patients.
And what's the name of the company?
It's called Sava Senior Care, and they do business in Fort Worth as Fort Worth Downtown Operating Company, or Downtown Health and Rehabilitation Center, and Fort Worth Nursing and Rehabilitation Center. And in Arlington, it's Arlington Heights Health and Rehabilitation Center.
So 3 facilities.
I think the one facility goes by 2 different names, actually.
Okay.
But I understand there's 2 different locations, and that they do have an agreement that they will have beds available for us as part of this.
Okay, any other questions for Wanda?
I guess, well, but JPS will be paying for the patients while they're in that facility.
Correct.
Okay. I guess the question is, do we know how long they'll have to be, who will determine how long they need to be in that facility?
There's a case agreement when they go, of how long it's estimated that the patient would have to stay. The average length of stay for those patients is about 21 days, but it could vary anywhere from 14 to 45 days, depending on the patient's individual needs. If there's an event where the patient would need to stay longer, that has to be negotiated with our case managers, and they're following those patients to make sure that that's required.
And how do, I'm sorry,
please.
this comes up in trauma all the time.
Please.
How do we know who qualifies? I mean, I guess it's, who meets criteria, who's qualified to go to these facilities? Is it JPS connection, for example?
Any of our patients that would require SNF,
Patient.
but if they have private insurance, or private
Yes,
insurance would
well,
pay
yeah,
for it.
private insurance is a separate category, but we get, especially in trauma, I mean, we've got at least a third of the patients are uninsured, and what to do with them. You know, that's always the challenge. And a lot of times they do sit in the hospital, and so anything that can alleviate that burden would be greatly helpful.
Yeah, I look at this as a good step
Yeah.
for that very reason.
Since we've closed our SNF unit and opened those 16 beds, they've been full every day. So it was greatly needed to have those additional 16 beds here.
SNF unit was great, it just didn't have that many beds. It was, you know.
Okay, further presentation. Any further questions? Entertain a motion. Motion by Mr. Nguyen, a second by Dr. Weber. All in favor, please say aye. Opposed, motion passes. Thank you, Wanda. Item F, Ms. Whalen. Good morning.
I'm here today to present the agreement between Siemens Healthcare and the district for a capital purchase of an automated chemistry line that includes 5 analyzers. What has happened in the last week is that 3 of our current analyzers have gone down, and we have brought them back up, and this event happened over about a 48-hour period. They are quite old, and we are hoping that these analyzers are going to continue to run, and so we're asking for an emergency PO so that we can start the manufacturing process and bring those analyzers in-house within the next 6 to 8 weeks. We think we can keep our current analyzers up and running during that time, but it's on a day-to-day basis for us. So this request is approval of the full purchase, which includes all 5 analyzers and the automation line, with the understanding that we know that this is going to be ratified by the full board in July.
Right. And this is in capital budget.
Yes, it is budgeted,
Right.
yes.
Any questions for Kathleen? Entertain a motion. Motion by Mr. Bose, second by Mr. Powell. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Thank you.
Thank you. Melinda? Good morning.
Kathleen could not make this any easier for me. So she wants to buy the automation line. So once we have that automation line, we need to be able to feed orders to the line for lab orders and get results back from the line. So this request is for the purchase of the interface from that line to Soft,
Okay.
our lab system. And
Questions?
those results then roll over to Epic.
Right.
I think we need that. I'd make a motion, we approve what we just spent.
He has no
I have
idea what you
problem
just said.
Making this motion after what we just spent on the previous one. Move for
Motion
approval.
by Mr. Powell, second by Mr. Bose. Any questions for Melinda? All in favor, please say aye. Opposed? Motion passes. Thank you, Melinda.
For what we just
Pardon?
spent.
And your exception to competitive bidding.
Oh,
You're approving the
Legal
exception.
counsel forgot to remind me of that.
Motion for, and also the motion to accept the fact that this is a sole source, your approval of the sole source.
Oh, we need a
exception.
motion to accept this as a sole source?
Yes, yes.
I'll entertain such a motion. Mr. Powell, you make
I
that?
would so move. It's my understanding this was almost an emergency. We needed the equipment and
Yeah, the one previous.
the previous,
goes
and then
along
this
with
one
it.
goes along with that. Are you covering them both?
This one's not under the emergency, but it's a sole, but it is a
Gotcha.
sole source.
Based
it's a
on the
sole
fact that
source.
we did the other one because of the emergency.
Right.
Mr. Early did call and then he did seek general counsel's opinion. So yes, I would make that motion to, this goes with the other one, so.
Thank you. Have heard the motion. Have a second by Mr. Bose. Any questions? All in favor, please say aye.
Aye.
Opposed, motion passes.
Yeah, thanks,
Thank you
Al.
very much. Thank you. Thanks, Al.
Yeah.
Thank you, Ms. Clark.
Is this I know we already voted on it, but is this gonna be one of those things that we come back every year and say, well, we're single source now, and so we're doomed forever? Or is this one of those things where next year we do something a little more sane and it's not sole source?
I don't know.
I'd have to defer to legal counsel on
Well, on
that.
this one in particular, I'd have to defer as far as this particular purchase, this thing going along with the Siemens equipment.
Right.
I think its interfaces, from the technical aspect, I think these.
Yeah, we evaluate every interface, everything like that. When we go to, before we bring it to you guys, we ask ourselves that question. Is this something that it could be sourced by other people? And usually then we go out to RFP for that. And so when you're asking, is this something kind of a year, we're not putting that on it. We evaluate every request and say, do we need to take this to sole source, or do we need to take this out to RFP? So there's really not a blanket or an umbrella that goes over this and says, okay, now that we've done this, everything else is grandfathered in. We don't look at it that way. We look at each individual request.
I'm just saying that, okay, so this ancillary contract we just approved, we're kind of doing this on a hurry-up basis. If I go to Fry's and I buy a computer, I can get a service contract, right then.
Right.
Or I can not do it. If I want to be high and tight, I go ahead and spend the money.
Right.
Knowing that I'm overpaying.
Right.
But I don't have to do that.
Exactly.
So, is this one of those things where next year, in this situation, will there be are there other potential people that can do this service?
So to answer that question, again, let's just talk about Soft, because that's who we're talking about right now. Soft Computer Corporation that runs the technology for our lab. It's built into their contract, and many software companies are like this,
Right.
that no one else can write code for their software, right?
Right.
So because of statutes that we have and policies that we have in place, that contract still doesn't suffice as a sole source. We still have to evaluate every request of interfacing that we do with Soft. We have to do that evaluation. Even though the contract says that nobody else can, we
Right.
still have to do that evaluation to keep them honest, saying, is there someone else out there?
I think
So what you're saying is exactly right. We either pay now or we take that risk, but we take that, we evaluate that each time.
Yeah, I think with companies like Siemens on equipment like this, they have it already built in that there's gonna be one, like an interface that can be provided to it. It's already built in. that you can pretty
Yeah,
much
with
use
Soft, we
it
have to pay each time we build it.
I saw a lot of organizations like this make all their money in the support.
Yeah.
Abbott Labs for, I just happen to I know those guys make all their money on the.
Kathleen might have
after
a-
the sale.
Yeah.
You're
And Warren,
100% correct on that.
I agree with what you're saying. I think, again, back to the big picture here, we had an emergency basically happen. We had to spend $1.6 million to get that equipment in here in the capital budget. This, I kind of see as, that $73,000 is kind of part and parcel to getting that equipment, maximum use out of that equipment, so.
Absolutely, but
But
in
it
full
doesn't set
disclosure,
precedence that we're just gonna
yeah.
go sole source all the, yeah. so
Yeah, we don't want to do that. In full disclosure, we wouldn't have done this sole source if it wasn't for the emergency situation. We would have evaluated it as.
Can we plan our emergencies better so we don't have this problem?
We
Coming
will
anyway.
absolutely, you know what, we'll put a timeline together for all of our unplanned outages as well and
Thank
all of
you.
our
That would be
emergencies.
very
That would,
helpful.
awesome.
Yeah.
Can you
Yeah.
do that? Can you get a spreadsheet?
If the
by-
minutes will so
Absolutely.
state that, I
Kathleen might-
support your motion.
Yeah, absolutely.
Kathleen.
I just wanted to mention,
Yes,
this
ma'am.
was not actually, this was planned. We
Right.
had the contract in legal in December, and it's been negotiated throughout that time frame. And we were going to bring it today for a regular purchase, but it just happened to have 3 analyzers go down this past weekend. So this purchase request for the PO was just because of this past
Right.
week.
It was going
It was
to be
on the
on their
agenda.
agenda anyway, just, we've had some.
We just didn't know it was going to.
Land emergency. So you said you can do it.
Kind of,
I wanna
yeah.
hear, complaints in the future.
I apologize.
Thank you, Kathleen.
Gonna have to get that older equipment to last longer. No,
More baling wire.
yeah, I want to, little since we're streaming, yeah, there was an immediate situation. It got resolved. I commend the staff. Robert made the call. He immediately checked with legal counsel. So I commend the staff. We had to take care of our patients. And I think that's the underlying mission of what we do here. So again, that's kind of how that thing all came about. So thanks to the staff. So thank you.
Okay, now for what you're up here for, David, item H.
Item H. So in front of you is a recommendation of a contract with NetSync. This is a new technology, virtual desktop infrastructure. It's a VDI. Many hospitals around the nation are moving away from PC-based care to thin client care, which basically means when a physician walks into a patient room, they don't have to sit there and wait to log in with credentials and get all the way through all the passwords and so on and so forth, and then launch applications. They can take their badge, they can tap, that's their security, they put in a PIN code, and whatever sessions they were running in a previous room or at their desk or in a hallway, it automatically transfers to that room, so they're immediately up and running. And so it will cut down hopefully physician reluctancy to move between room and room, because that's a big deal. Because when they have to sit there and log into Epic, and it may take 15 seconds, 30 seconds, a minute sometimes to log in through all the applications before they can see a patient. Now with this infrastructure, it'll be a tap, and they'll be up and running within 5 to 7 seconds in that room. And that's a really big deal. There's also a security component to it, because we have all of our PCs that are logged in underneath generic passwords, and now we can remove that vulnerability from the infrastructure, so we don't have those generic passwords. So this recommendation is considered for a phase 1. We'll be doing the patient care pavilion with this technology throughout the next 9 to 12 months. And depending on the baseline that we create with that, then we'll be moving into a phase 2 as we learn what the real capacities and throughput and volume is for that technology.
Awesome. You've heard the explanation from David. Any questions? Yes, sir.
I've heard that at some point you're gonna put your finger or put your eyeball up to something. and
Right.
that'll be-
That'll be your authentication.
That's your identification, yes.
So,
That's-
so there are 3 factors of authentication that are considered. The first is a username and password. The second one, so that's what you know. The second one is what you have, so a tap from a badge or something else like that. And the third would be some type of biometric. Now, more and more hospitals and HHS and CMS are coming down that single-factor authentication is no longer enough. You need 2-factor authentication to be able to do certain things. I don't know the recommendations of a 3rd-factor authentication. That's not on the table yet, but 5 years from now, that very well could be. So that 2nd-factor identification could be a biometric if we want to. We can say no more taps with a badge. We can say do it with a thumbprint if you want to. We'll make that determination as we roll out this technology.
So what's the follow-on to this? Because, so we got 2 million here, so is it gonna be another 500,000 next year?
So this is for the patient care pavilion. So we put into the budget for next year another 1.7 million. Almost, we had originally put 2.7 million in the budget for this year. That didn't make a lot of sense for what we were trying to accomplish. So we were able to whittle that down a little bit. We put 1.7 million in the next year, but that may come down significantly based on this baseline. So this baseline may tell us that we can not only do 500 workstations, but maybe we can do 2,000 workstations. We won't know that until we get the technology in and see what the throughput of our physicians and our nurses are. Once we do that, then we'll be able to adjust the budget next year appropriately.
Are we actually buying, iPads, or are we buying, what are we getting here?
So
I know we're getting software, but
right,
it's
so
just-
we support 6,500 workstations around the district. What we'll be doing is taking out the workstations in the pavilion, the PCs, taking them out and putting a Wise Thin client behind every monitor. Now, Wise Thin client really has no brain to it. When it boots up and turns on, it goes to our data center, gets its entire image thrown to it, and at that point, it then displays a screen for the physician or clinician to be able to say, do I want to put up Epic? Do I want to put up Outlook? Do I want to run Internet Explorer to get to the intranet? What am I doing? So it takes all that security away from that individual workstation. So we're purchasing those thin clients, we're purchasing the infrastructure and the data center. As you can imagine, we're taking all that workstation compute power and putting it into the data center as opposed to being at the local level. So then we can control software upgrades a lot better. So right now, when we do a new version of Epic, we have to push Epic to 6,500 workstations. That takes 2 to 3 days to accomplish. With this technology, when we push a new build to Epic, it's done in 45 seconds because we copy one image and it goes across the entire.
Code Red, main campus, OPC, 3rd floor. Code Red, main campus, OPC, 3rd floor. Attention, please, Code Red, main campus.
This may be an exaggeration.
They saw my temperature go up because of these questions, so they called the code.
So when you do this, did you just roll it out at one time, or do you, how does this?
It's really, so we build the infrastructure in the data center. So once we build this infrastructure in the data center, then it really is a replacement one at a time. So we'll go to a nurse's station, replace those 5, and they're up and running. Go into like the ICU and the ER and replace them on a weekend or whenever we can to get in there to be able to do it.
So what's gonna happen to all the PCs?
So the PCs are, one of 2 things happens to them. So we have a 5-year recycle project for every PC that we have in the district. So we will scan those into our asset management system. Anything that is beyond 5 years goes through our normal process and goes to the recycler and the decommissioning organization that takes care of it. Anything that hasn't met that 5-year mark will then be put back into queue for any purchase that we need to do or any new person that we hire or any other replacement that we need to do. So we have a pretty solid asset management system and recycling of things that we do every time we take out a PC and do something different.
Boat anchor. Boat anchor.
Boat anchors, some of them
Doorstop.
could be.
Okay, you've heard David's
So we're
explanation.
going back to the old mainframe.
I tell you what, things are going back to centralized control of mainframe, absolutely.
Yeah.
Is this going to replace some of the single sign-on that we have to do?
This
later
will,
on?
so I thank you for asking that, and Warren, I meant to mention that. One of the other things that we are purchasing with that is Improvada's single sign-on application as well. So that's one of the things that's part of this initial purchase. And all the tap badges so that a physician or clinician can walk up with their badge, tap, and that session comes. So all of that infrastructure is included in this
Yeah,
purchase.
everything's going towards single
Yeah.
sign-on. Yeah.
Yep, everything's going single sign-on.
No savings? No, I'm just kidding.
There actually are, because these things are rated at 7 to 8 years as opposed to the 5-year PC cycle that we go through now.
Okay, any other questions for David? Entertain a motion for approval of.
So moved.
We have a motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. All right, David, you're on an aye now.
So this is a recommendation to purchase the new technology for our Epic and soft systems, as well as ChartMax. We currently run on IBM AIX Power 7 boxes that have been running for about 8.5 years now. So prior to the installation of Epic, when the contract was signed, these were the first pieces of technology that hit our dock, and so that we could start building up Epic in all of the environments. So this particular piece of technology, all of these AIX systems have been running for about 8 years, very flawlessly. However, the next version of Epic will not run on this infrastructure. And we are slated to be going live on the next version of Epic, the 2017 version, in June of next year. So,
Attention, please. Code red. Main campus. OPC third floor is all clear. Attention, please. Code red. Main campus. OPC third floor is all clear.
So-
Attention, please. Code red. Main campus. OPC third floor is all clear.
So is this operating system agnostic, so that you can bring in different, because
no,
Epic is on MUM, so.
So this hardware is IBM hardware. It's not operating system agnostic. It has to run the AIX platform on it. But when we look at applications to be able to do it, we either run applications that are AIX or we're running as Windows applications. So the MUMPS database from InterSystems will be running on this without any problem. We're actually just this is gonna be the hardware stack. We have the storage stack. When we put the hardware stack in place, all we do is repoint it to the storage stack, and it's up and running at that point. Yeah.
Okay, heard David's explanation.
Move for approval.
Motion by Mr. Nguyen,
Second.
second by Dr. Weber. All in favor, please say aye. Thank you, sir.
Thanks.
Okay, Jamie, item J. J for Jamie.
Good morning.
Good morning.
So just to clarify that code red, we're doing testing for the fire marshal.
Got it, thank you.
I thought it was David's hot topic, though.
So I'm presenting a purchase agreement to add or replace chillers and boilers at 4 of our clinics. This equipment has exceeded its useful life and has become very difficult to maintain and repair. Just finding the parts needed to repair this equipment is challenging. We sent this out for RFP and received 3 responses. I'm asking the committee to consider our recommendation to approve the agreement with Acumen Enterprises Incorporated to purchase and install boilers and chillers at the clinics.
Any questions for Jamie? For approval?
So moved.
Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Jamie.
I
Item
mean, they're
K.
going to be excited about those air conditioners and those coolers being replaced
Yeah,
in this weather.
absolutely. Item K.
I am presenting a purchase agreement to update our current parking gate operation. The current system is antiquated and service and parts are no longer available. We've been salvaging parts from other companies who have similar gates for the past 3 years now. So this current gate technology has exceeded its useful life. The service from the manufacturer has been discontinued. Obviously, this will improve our customer service by allowing our booth attendants to handle cash and credit transactions out of the window versus using the self-pay stations. We sent this out for RFP and we received 5 responses. I'm asking the committee to consider our recommendation to approve the agreement with SkiData Incorporated to purchase and install the parking access and revenue control system for the garages.
I will comment that I was effectively lobbied by the booth attendants as I came in. Good job, well done.
Dale probably had them do that too.
The explanation by Jamie. Any questions for? Entertain a motion for approval.
Recommended approval.
From Dr. Weber, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Thank you very much, Jamie. Appreciate
Thank you.
All right, we're going to recess and reconvene in closed session. We
Real
have,
quickly before you
Oh.
do, I just add the $200,000 contracts under.
oh, would you turn your
$200,000.
computer thing on?
The, just real quickly under item 6, the contracts under $200,000 report, we have 32 contracts on that list. Those are all available
On the portal.
portal in the library for anyone to examine, so.
Okay,
just-
great.
That's it.
Thank you for that.
Mhm.
We have an item in closed session, so we'll close and reconvene in executive session. Thank you all.